Hello, everyone. Thank you for joining today's webinar, Reward-Induced Health Literacy, a key to improving employee health and reducing costs. This webinar is sponsored by MedIncentive. MedIncentive is a health improvement cost containment service for employers, insurers, and governments. The company's web-based and mobile-enabled mutual accountability and information therapy MATE program employs a patented, aligned incentive mechanism proven to improve health and healthcare and lower costs, an objective often referred to as the triple, quadruple, 12-part aim. What makes the MATE program unique is how it offers financial incentives to both patients and doctors for holding each other accountable for completing an educational and motivational process called information therapy, which is known to mitigate the ill effects of inadequate health literacy. I'm Sean Edwards from World Congress and Validation Institute. I will be introducing our webinar today. Just a couple of quick housekeeping items. Due to the number of attendees, participant lines are muted. However, if you'd like to submit a question for our speakers, please do so using the Q&A feature that you see at the bottom of your screen. We'll answer all questions that we have time to address during our session today. Also, please note the webinar will be recorded. You'll receive an email with a link to the video so that you can view it again. Now I'd like to introduce our MC for today. Jonathan Fullerton is the co-founder and president of Green Robe, and we are pleased to have him here. Jonathan, thanks for being here. Without further ado, I'm going to turn things over to you.
Thank you so much, Sean, and good afternoon for those of us on the East Coast. For everyone else in the country, good morning. We are so excited to have you join us today to learn more about this critical topic of health literacy. As Sean mentioned, I have the honor of serving as your Master of Ceremonies today. I also have the honor of introducing our panelists and running through our agenda. So let's go ahead and hop right in and let's review what's ahead over roughly the next 58 minutes. Each of our presenters represent key members of the field, and each are going to share some key insights as it relates to health literacy. We are going to begin with Dr. Jolie Hahn, who's an affiliate associate professor at the University of South Florida College of Public Health. Jolie is going to spend time explaining why health literacy is such a hidden obstacle to our collective efforts to reduce healthcare costs and more effectively engage our employees in their care. So she's going to frame this issue for us and really help us understand the challenges it represents for our healthcare system. Next, we'll turn to Jeff Green, who is the CEO and co-founder of MedIncentive. Jeff is going to provide an overview of the MATE program and talk about why their solution, which leverages and builds upon the physician-patient relationship, can be a key lever in helping to overcome the challenges that health literacy produces for our health system. Next, Al Lewis, who is the CEO of Quizify and the Validation Institute co-founder, is going to talk about the process that they pursued to validate the outcomes that MedIncentive is achieving for their customers. He'll also talk about what this might mean for employers. And then finally, certainly not least, but last in our panel is Pam Owen, who is a principal at Buck Global Consulting. She'll talk about why Buck adopted the MATE program and how they have been promoting it to their customers. After the panelists are done with their presentations, we will turn to our panel discussion, which will be moderated by myself. And then finally, we've set aside time at the end of our conversations for your Q&A. And as Sean mentioned, please enter those throughout the conversation, and you may do those through the Zoom chat function. Okay, that is our agenda ahead. I am going to go ahead now and turn it over to our first presenter, Dr. Jolie Hahn. And Jolie's going to spend some time here at the outset, giving us a little bit about her background and her role. Dr. Hahn, welcome, and thank you for joining us.
Thank you for having me. I want to thank everyone for joining our presentation today. Today, as he mentioned, I will be providing a brief overview on health literacy and the relationship between health literacy and healthcare costs. Relevant to this presentation, in my previous research, I validated a brief 4-item tool to assess patients' health literacy needs in the clinical setting. This tool was subsequently integrated into a region in the Veterans Health Administration's computerized patient record system. This resulted in the tool being used to assess that patient population. For this work, I received the National Patient Safety Foundation's Pfizer Health Literacy Award in Advancing Patient Safety. Subsequently, I accessed that health literacy assessment data for the region's patient population to conduct one of the largest secondary studies to test the association between health literacy and healthcare costs. In the last several years, my 4-item health literacy tool has been disseminated throughout the United States, within and outside of the VA, and in several other countries in multiple languages. I will briefly review my study as well as other work that has been done to establish the relationship between health literacy and healthcare costs and utilization in this presentation. Next slide. Though health literacy was coined in the 1970s, we didn't really see the term in academic literature until the 1990s. Since the 90s, the issue of health literacy has experienced exponential growth in attention to the measure of this health factor and its impact on healthcare experience and outcomes. Briefly, the definition of health literacy is the degree to which individuals have the capacity to obtain, process, and understand basic health information and acquire services needed to make appropriate health decisions. As such, an individual's capacity to exercise these abilities has shown to have significant impact on a multitude of outcomes. Next slide. Functional health literacy is the ability to read and comprehend prescription bottles, appointment slips, and other essential health-related materials required to successfully function as a patient, among other skill sets. These functional tasks are the key to healthcare management. As such, when health literacy skills are compromised, it can lead to adverse outcomes and increase healthcare costs. Next slide. It is important to note the magnitude of low health literacy. Nearly 36% of Americans have low health literacy. In our current population of 328 million Americans, there are approximately 118 million Americans with low health literacy. On average, these individuals have adverse outcomes, including higher healthcare costs, more hospital visits, and longer hospital stays. How do these outcomes occur, you ask? Next slide. Because people with low health literacy miss clinical appointments, provide inaccurate or incomplete histories, are non-compliant with treatment and self-care regimens, are less likely to seek preventative care, and are double the risk for hospitalization, and have difficulty navigating the healthcare system in general. Next slide. These behaviors lead to medical errors, unnecessary hospitalizations, extended hospital stays, medical non-adherence, delayed onset of healthcare, and compromised disease management. Now, logically, we might hypothesize that these adverse outcomes result in increased healthcare costs. But what we want to know and talk about today is, what does the research say? Next slide. In one of, if not the first, published estimates in the 90s, the Health Policy Institute estimated that 40 to 44 million American adults are functionally illiterate and 50 million are marginally illiterate. Additional healthcare expenditures due to low health literacy skills, meaning above and beyond the costs associated with adequate health literacy, are about 73 billion, and this is in 1998 healthcare dollars. Next slide. Now, in 2015, I published one of the largest, if not the largest, cost studies with a sample of 92,749 veterans. I longitudinally assessed their utilization from 2007 to 2009. Now, it is worthwhile to note that the original sample was over 100,000 veterans. It was about 112,000. Veterans representing those in all of that region, the entire population. But we opted to only include the 92,000 veterans who had established cost data across all 3 years from 2007 to 2009 to have a complete longitudinal set of data. The average per patient cost for those with inadequate and marginal health literacy was significantly higher, inadequate being about 31,000 and marginal being about 23,000, than those with adequate health literacy, which was about 17,000. Estimated 3-year costs associated with veterans with marginal and inadequate health literacy was $143 million more than those with adequate health literacy. These data suggest that 17.2% of the population accounted for 24% of costs over the 3-year period. Meeting the health literacy needs of this population could produce a savings of 8% of the total cost for that population. Next slide. With consistent data used from the National Assessment of Adult Literacy using a health literacy component of the survey, in 2007, Vernon and colleagues estimated the cost of low health literacy in the US economy is between 106 billion and 238 billion annually. That is 7 to 17% of all personal health care expenditures. Given the costs associated with my sample of 92,000 veterans, and the number of Americans with low health literacy, this is a reasonable, if not conservative, estimation. Collectively, large-scale studies and secondary data estimates have illustrated the significant and costly relationship between health literacy and healthcare costs. Next slide. In summary, low health literacy is a critical health factor that impacts millions of Americans who, when the needs go unmet, cost the US economy billions of dollars. Thank you for your time, and please enjoy the rest of today's presentation.
Thank you, Dr. Hahn. That was a very speedy but very enlightening overview of the challenges that inadequate health literacy is creating for our industry. We'll be looping back with you during our panel and Q&A session. So I have some questions for you as well. So we'll put those on pause until later on. For now, I'd like to transition to Jeff Green, who is the CEO and co-founder of MedIncentive. You heard Sean describe MedIncentive as we launched our conversation today. Jeff is going to sort of tell the story of MedIncentive and how the solution positively impacts some of the detrimental occurrences that health literacy leads to today. So Jeff, I'm going to go ahead and turn it over to you. Welcome, and thank you for joining.
Thank you, Jonathan. Can everyone hear me? So my task is to describe the MedIncentive MATE program. It is a proven solution to mitigate the ill effects of inadequate health literacy. And before I get started, or I guess the best way to describe the program is to provide a little bit of background. I'm a human factors engineer, and I invented something called the trilateral health accountability model, for which I hold 3 US patents and a Canadian patent. I became a practice management consultant years ago and built one of the largest practice management billing companies in the country. I, at the same time, taught third-year residents the subject for 18 years at the University of Oklahoma Health Science Center, co-authored a book published by the American Academy of Family Physicians on the subject that was used as the text of choice in residencies across the country. So I practiced what I preached, and I preached what I practiced, and my business grew and my doctors prospered. And invariably the doctors would ask me, Jeff, what's your next best idea to help us make more money? That was all well and good until my business became self-funded. So that meant that Mr. and Mrs. Green became the insurer for our employees. So the next meeting that I attended with physicians, and when they asked me for my next best idea, I pushed back and said, now I'm the insurance company. So what we've got to do is we've got to find a way to get you an increase in pay that lowers my cost as the insurer. And I've observed as the insurer that I have very little influence on the behavior of my employee and their family member. And that, in fact, they expect me to provide the benefit and to basically butt out. And I have even less influence with their doctor. But I observe that the two of them have considerable influence on one another. And I suggested that perhaps we could have insurers reward both parties simultaneously to hold one another accountable for something that would improve health and lower cost. And that something became information therapy. And it's defined as providing the right information at the right time in the right way, so the patient is better educated and more motivated to self-manage their health. And it is related to health literacy. And so that's where I'm going to delve into where the health literacy movement stands today in our country. This slide indicates that back in 2010, 11 years ago, HHS initiated the National Action Plan for improved health literacy. And it states that all people have the right to health information and that health services should be delivered in a way that people can understand. Next. So why has there been so little movement? Well, this graphic quotes Michael Abrams. It says that the movement has been slow. And part of the reason for that is, next. Back up. Yeah. The reason that it's been slow is that hospitals in general have been late to addressing the problem, and that the movement has really been led by not-for-profit advocacy organizations. Next. He goes on to say that hospitals, when they get paid to fix their mistakes, really see health literacy as something that does not support that business model. Next. And he concludes by saying that this is going to take a while. It's going to be a slow process, but that value-based risk will accelerate the process. Next. So as Dr. Hahn indicated, all kinds of bad outcomes occur as a result of low health literacy. And yet there has been essentially no innovations in the field. So why is that? Next. Next. Let me introduce you to the curse of knowledge. It's a cognitive bias that afflicts smart people. Next. That unknowingly assume others understand what they know, or fail to appreciate what others don't know, or fail to realize what they themselves don't know. And I can tell you that I've presented our program and the issue around health literacy to a lot of highly educated and smart folks. And I am continually surprised when they say, Jeff, is health literacy all you've got? Next. So things are changing. With the advent of value-based care, there is more attention on health literacy. And I'll explain why that is. But for the first time since its inception in 1979, HHS's Healthy People Initiative has identified health literacy as an overarching priority, a central focus. And of their 6 objectives, the first 3 have to do with the doctor-patient relationship, as these bullets indicate. So the doctors, the initiative wants doctors to be better communicators. They want patients to report that their doctors have communicated with them poorly on less frequent basis, and they want to increase the amount of shared decision-making. Next. That's all well and good, but people need to understand, we all need to understand that the clinic setting is one of the worst places on earth to teach somebody something that they need to know. Doctors are in a hurry, patients are distracted, and communication is not effective, which produces all kinds of calamity. Next. So my task, as I mentioned earlier, is to share with you the Med-Incentive MATE program, which is this proven innovation to address all of these issues. And I'm going to begin with a little bit of behavioral science. So next. We know that when people learn how and why, they become empowered. Empowerment is a component of motivation. Motivation leads to adherence. And there is a term that describes this phenomena. Next. It's called the KEMA response, the knowledge, empowerment, motivation, adherence response. Next. In the Med-Incentive program, the KEMA response is accomplished by providing the patient with the right information at the right time in the right way so they can be better educated and motivated to self-manage their health. Next. And as I mentioned earlier, the term that describes this process is called information therapy, big I, little x. Next. Another thing that we observed, as I mentioned when I was a self-insured business owner, is this misalignment of incentives. And what we believe, or what we know, is that no health improvement cost containment initiative can be effective and sustained until the interest of these three key stakeholders are properly aligned. And yet in this country for decades now, insurers have practiced two incentive processes, one in which the insurer incents the patient. Next. Examples of this are wellness and fitness, high deductible consumer-driven health plans, disease management. And the characteristic of this approach is that the provider's left out of the equation, and therefore this method of incenting behavior change is not very effective. Next. Conversely, the approach of incenting providers, which includes HMOs, ACOs, any kind of pay for performance scheme, has failed to be effective because the patient is not held accountable for anything, which prompted famed Harvard professor Clayton Christensen to say, in other words, ACOs hold caregivers accountable without requiring patient accountability. How can this work? Which we agree with wholeheartedly. Next. So the Med Incentive Program is based on a patented process that combines human factors engineering with web technology and behavioral science. Next. That improves health and lowers costs by tapping into the doctor-patient relationship and employing information therapy to mitigate low health literacy. Next. The way it works is that health insurers, including self-insured employers and commercial insurers, Medicare, Medicaid, purchases a program and bolts it on as an additional benefit. The insurers then arrange for claims data to be transmitted to the program's computer on a daily basis, eligibility data transmitted electronically at least monthly. And with this data, the entire process is automated from that from that point forward. Next. So the program's computer system sifts through the claims, identifies the office visits, which is the event that initiates an opportunity for both the doctor and the patient to participate and earn a financial reward. The doctor's experience begins with a notice that is sent to their office, directing them to the website. There they find a list of articles arrayed in relevancy order to the patient's diagnoses that has been harvested from the claim data that has been transmitted. Next. So the doctor simply selects one of the articles as homework. It's described as an information therapy prescription, 30 seconds or less. So it's fast, easy, relatively lucrative. It can be delegated to staff. So if the doctor doesn't want to spend the 30 seconds, he or she can delegate it to office staff. It's impactful, but more importantly, it is the right thing to do because, next, the patient's experience. It begins at home after the office visit, where patients receive a letter or an email directing them to the website, informing them that they can earn a financial incentive in an amount equal to the doctor. Doctor can earn up to $15 per office visit paid by the insurer. Patient can earn $15, again, funded by the insurer, for doing 5 simple things. First, read the prescribed information, educational content. And if the doctor hasn't participated, the patient receives the list of articles and they can select their information therapy themselves. So they're never deprived of the opportunity to participate. The second step is the patient is asked to take a test. It's open book, so they can't fail. I might add that this is the first time in medical history that anyone is routinely assessing a person's understanding of what they need to do, what they need to know in order to self-manage their health. The third step is also a first in medical history, in that patients are asked to declare their adherence to what they've learned or provide a reason for non-adherence from a list that includes, I can't afford it, makes me feel bad, I don't think it's effective, whatever the case may be. The fourth step is the patient must agree to allow their doctor to see their literacy score and their declaration of adherence. That invokes the Hawthorne effect, which I'll explain a little bit later. And then finally, the patient is asked to rate the doctor's performance on a scale of consistent to inconsistent against what they just learned. So what we have now is a learned, discriminating patient rating the doctor's performance against a diagnosis, which is, in our opinion, superior to the CAP surveys, health grades, much fairer, much more objective than either one of those rating methods. So that's basically how the program works. Next. In the process, what's happening is that there's this dynamic between the doctor and the patient that's called mutual accountability, both parties being accountable to one another. And that's why the program is called, next, the Mutual Accountability Information Therapy, or MATE program. Next. So behind the scenes, even though this may seem a bit straightforward and simplistic, there are a number of psychologies that are being invoked, to include the chemo response, promise keeping, guilt aversion, the Hawthorne effect, which I mentioned earlier, which teaches that in the presence of an authority figure, we're on our best behavior, especially if that authority figure is someone we trust and respect, like our physician. Covenant conditioning, loss aversion, behavioral economics, to name many of the psychologies that take place as a result of the program, which nudges patients' behavior and doctors' behavior to improve outcomes. Next. So what this does to the three-legged stool is that it introduces an intermediary between the doctor and the patient. Next. That uses, next, information therapy. Next. To mitigate the ill effects of inadequate health literacy. Next. By using this process of mutual accountability. And when the program authenticates these transactions by either one or both of the stakeholders, the patient and the doctor, the program sends a signal to the insurer, next, to reward one or both parties. And then the expected outcome, next, is that the insurer realizes savings to offset the cost of the program and produce a return on investment. Next. So by design, it's intended to achieve the quadruple aim, which is better health care, lower cost, patient and doctor fulfillment. So let's see how the program is done against the quadruple aim. First, in terms of how doctors feel fulfilled, this slide shows that the program, and we were identified as the Patient Advocate of the Year by the Oklahoma Academy of Family Physicians. The first time that a non-physician, non-elected public official was selected for the award, which simply says that when doctors know about the program, they embrace it. Next. In terms of patients' responses, we get literally thousands of written testimonials posted to our website. This slide has photos of my colleague, Jim Dempster, standing in front of over 6,000 petitions signed by public employees asking the state of Oklahoma to expand and extend a pilot that was taking place at that time. So it's very popular with patients. Next. In terms of health and cost outcomes, the first graph illustrates hospitalizations pre-post. It demonstrates a reduction of nearly a third hospitalizations. And note that not only did it drop dramatically, but it was sustained over an extended period of time. So not only is it fast acting and expeditious, but it also is sustainable. The next is ER visits, which dropped double digits. Next, per capita cost dropped 11%, or nearly $3.8 million. Next, which when compared to the $500,000 that the plan sponsor, this plan was about 1,800, 2,000 plan members and a self-insured business, produced a 7.5 to 1 ROI. Next. So according to the Validation Institute, this is the first and only peer-reviewed, validated solution to achieve the quadruple aim. Next. And very simply, the reason it works is that people don't want to be unhealthy. They want to have the knowledge to self-manage their health. And lastly, they want their doctors to not think they're health illiterate and non-compliant. And as a result, by combining mutual accountability and a reward-induced information therapy, it mitigates the ill effects of inadequate health literacy. If you'd like to learn more, Dr. Susan Chambers and I authored a white paper that's available on our website at medincentive.com.
Thank you, Jeff. Excellent overview of a truly fascinating solution. We will be coming back to you again during our Q&A and our panel discussion. Speaking of the validation of the data that Jeff just walked through in terms of the outcomes that the Med Incentive Program generates, I'd like to turn it over now to Al Lewis, who is the CEO of Quizify and the co-founder of the Validation Institute, which independently looked at the outcomes that Med Incentive had generated and in fact validated that they were correct. Al, I'm going to go ahead and turn it over to you. Thank you so much for joining us today.
All right, well, thank you very much for having me, and you can go to the next slide. So the Validation Institute has a credibility guarantee, which says when it validates something, it is validated. It's not like, oh, we paid a bunch of actuaries to do this. So if you see something validated by the Validation Institute, it's real. Next. So there were 6 tests. One was, the first is regression to the mean, which is, well, we'll show examples of each. Regression to the mean, participation bias, and trend inflation. We won't actually get into the others in the interest of time, but there is a 7-part series on the Validation Institute website where you can test what your vendor is saying against these 6 tests. Next. So there's no regression to the mean. Now, this is a real brochure from a real vendor. And what they're doing is they're just counting the people who are high risk and saying, look at how much we're going to reduce their risk. They're not looking at the people who are low risk and realizing that, well, people gain weight and they lose weight, they quit smoking, they start smoking again. They're not counting any of that. And the way you know they're lying is that 2/3 of the people are in the yellow lower bar there. The 2/3 of the people are smushed into that lower third. So we check that against Med Incentive. The next thing is they count everybody. Now you notice that they count admissions per 1,000 and they count ER visits per 1,000. They don't say our participants outperformed our non-participants because here's a news flash. Participants will always outperform non-participants. And what this slide shows, and we'll go through it a little bit slowly, is that it's not only the case, this is the best example of that, because if this particular example, which won an award from the Wellness Trade Organization, they took the participants, you volunteered to participate in 2004, and then they did what they call matched controls. And whenever you see the word matched controls, you know it's made up, and Med Incentive did not do this. That was the orange group right there. So the people who didn't want to participate, some large number of them became the matched control. Now, if you just look at the 2 lines going for 2008, it looks like, well, the participants had much lower cost than the non-participants. The program must have worked. However, if you look at the baseline year, you can see that the actual quote unquote treatment did not start until 2006. So there were 2 years during which the participants did not have a program to participate in, and yet they did dramatically better than the non-participants did over that period without a program. And this happens time and time again, but it did not happen with med incentive. We checked this stuff against med incentive. And by the way, we don't accept everything that they say when we do a validation. So for instance, the initial admits per thousand were in the high 80s and low 90s. And we said, well, that's just too high by itself. So when we validate the admissions rate per thousand, which you saw was in the mid 50s, mid to high 50s, against the standard 63 to 65 that everybody else gets. So they got validated, and this is often the case, that it's almost always the case that a vendor can get validated, but not for everything they want. The difference with med incentive is that even when you take out that stuff, they still end up saving money. They still end up having a program that works. And I don't say that lightly, because when they came to the Validation Institute, I was pretty sure that this wasn't a thing, that it wasn't going to work. So I kept sending them back to do more analysis, and they kept coming back with the quote unquote correct answers. So I'm quite confident that that there is some daylight in there between cost and some daylight of savings in there. Next. Now, the other thing, which they did not do, because if you look at the previous slide that Jeff showed, it's all based on units of care. There's not, some let's draw a trend line and say, oh yes, we maybe didn't reduce cost, but we reduced cost versus trend. No, Jeff showed units of care in the ER and inpatient, and then savings in actual dollars, not dollars versus some trend. And this is a counterexample that just came out, and I'm taking out the name, but you can ask me, I'll give you the name, where a vendor hired actuaries, and anytime a vendor hires actuaries, they're going to show savings. That's what actuaries do, to validate that, that their clients did better than a trend. So the actuaries do a trend line of 8%, and they said, well, ours were 0, so we saved 8%. Next slide. And the way you knew that was nothing but trend inflation was that they separated out this group into 4 comorbidity groups, 0, 1, 2, 3, and 4 comorbidities. Now, in this particular type of care coordination, you only call the care coordinators if there's stuff wrong with you. And even then, most people don't call, but there's no reason for anybody to call who has nothing wrong with them. Well, the vast majority of client members, 18,362, had not 062, had nothing wrong with them, had no reason to call. If they had called, there wouldn't have been anything that a care coordinator could have done for them because they don't have anything wrong with them. And yet somehow they saved 8% because the actuaries drew a trend line. We don't allow that. Med incentive did not do that. And then I think we got one more here. Meaning next, yeah. So to summarize, the outcomes that are validated are totally on the level. And along with the VI, Validation Institute Credibility Guarantee, you have my personal word that the measurement is valid. As the author of the only book on measuring healthcare outcomes, which was named by Forbes as Healthcare Book of the Year. Full disclosure, there was not much competition that year. I will vouch for them. Thank you very much.
Thank you, Al, so much. And for attendees, in case you can't tell, Al is on a passionate mission to force vendors to actually present outcomes data that is defensible, transparent, and reliable. So to learn more about the work at Validation Institute, I encourage you to go to their website. In addition, just to quickly note before we turn to Pam, Validation Institute and Med Incentive have created a first of its kind partnership to guarantee, in essence, the results that Med Incentive generates for customers. So to learn more about that program and that partnership, we encourage you either to reach out to members of the Med Incentive team, or details of that program is also available on the Med Incentive website. Al, thank you again. I can't support you enough in this effort. There's so many claims out there that are just outrageous. So it's exciting to see a vendor be independently validated in terms of their impact on what has been such a thorny issue for us to overcome. Okay,
Well,
turning
that's
now
very
to
nice
our,
of you to say.
you
I was
bet.
going to say,
Okay.
it's very nice of you to say if I had my video on it, I'd be blushing.
Wonderful. All right. Let's turn to our final panelist today. Pam Owen is a principal at Buck Global, and Pam is going to talk about her experience with MedIncentive and what really inspired her to introduce this both to Buck as well as to her customers. Pam, welcome, and thank you for joining.
Thank you, Jonathan, and thank you all for attending. The simple answer as to why Buck adopted MedIncentive is that the positive financial and health improvement results our client realized, and of course the results you and the Validation Institute have confirmed for this client and others, compelled us to likewise help our own employees. Being employed predominantly by consultants, we tend to have the curse of knowledge that Jeff described earlier. I'd like to present a case study that convinced us that not only should we inform other clients of the need for health literacy, but we needed it for ourselves. So we really believe mutual accountability and information therapy works. And just to explain why this is so essential to what we do as consultants, our job is to bring value to the client by helping them develop programs and plans that will support their population in a way that their cost, of course, will be managed or go down, mitigated. But as important and probably more important is to improve the health outcome of these individuals, of the members. And so we had a client come to us with a very large problem. They had 10,000 employees. Their costs were skyrocketing, and they had very, very high incidence of diabetes within that population. In fact, it was their #1 cost driver. This is a national healthcare provider that provides correctional industry healthcare. And their cost was just off the wall. So of course, as consultants, we have the curse of knowledge. We went out and decided, okay, we have some knowns. Logically, it would make sense that we would find a diabetes program that could start to make a difference in this population. So we, of course, did our due diligence. We came up with a very, very good diabetes program. And it was an exciting program, we thought, because the employees paid nothing for it. They got a lot for it. They got free supplies, etc. And this was something that was really going to make a difference. I also have to point out that not only did the healthcare provider have cost associated with their employees, the claims that are incurred, obviously, but they also had contractual costs. If these healthcare workers did not show up because they were sick, there is a penalty, a stiff penalty that the company has to pay. So that was an additional cost, not to mention just the cost of absenteeism in general. So we were real excited about the program. We put it in and with very high hopes, and we had 1% participation. Now, I have to also say that we did communicate the program, and not just once. We didn't just turn it on and let it go. We did diligently communicate the program, but still only a 1% participation rate in this really good diabetes program. And we realized this is not going to cut it. We really have to find something that's going to help these employees engage in this program. So we had to get to the crux of the problem. What was the problem? And what would we do to solve it? Well, the problem was, by and large, either A, employees were not seeking the right health care from their primary care or specialist, their endocrinologist, and not maintaining their health through the diabetic program. They didn't feel they could afford it. The other problem, though, is that they didn't know they needed it. You know, again, the curse of knowledge, you don't know what you don't know. So when Jeff and I met many years ago in an airport, and we discussed this, and it was very intriguing to me because I'm also a data wonk. I'm very much involved in health data analytics and the patient-centered medical home, how we really get the providers to provide better quality care. So this was very intriguing, and over time, we decided at Buck that this is the right thing for this client. We're going to give it a go and see how it works. And we implemented the program. The employees loved the program, absolutely loved it. I never had one complaint about the program, which is not always the case with well-being programs. And the members were actually incentivized to participate in the program, as Jeff has described. And this also helped to offset the copays or the deductible amounts for going to their primary care or specialist physicians. So now we're beginning to have this mutual accountability, but also a financial barrier is being lowered. I can't say it's removed, but it's definitely being lowered. But more important is the employees and the members, their families, we're beginning to understand, and keep in mind, this is a healthcare company. By and large, these are physicians, nurses. We were a little skeptical at first. We were going, wow, how are we going to tell nurses and doctors how to take care of themselves? We got some of the best testimonies right from the physicians and the nurses. And some of the physicians were even saying, I learned things that I relearned things that I had learned previously in my medical training. So this was very exciting for us. And we just saw the results take off, especially when we actually got the data on a daily basis. That's when things really took off, as you can see from the slide here. And the results were a win-win. Again, the first year we had participation in the diabetes program up 10%. Now we did measure these cohorts to make sure they were the same people that participated and that they participated in the med incentive program. And then, it fostered a behavior change. So, we now, of course, talk health literacy to all of our clients, and we talk med incentive to all of our clients, not because we're prejudiced or biased toward a vendor. That's not the case. It's toward a solution, and that we're very solution oriented. So, the one thing that just topped everything is not only was the participation high, but we saw a 1-point drop in HbA1c scores. So anyone who knows anything about diabetes, that was absolutely off the charts, and we were very excited. So we now have it at Buck, and we love the program as well. So thank you very much, Jeff, for that program, and we look forward to continuing that.
Awesome. Thank you, Pam. I appreciate your overview. That's very helpful, especially as both someone who is offering the program to your customers as well as using it at Buck itself. I think that's a really interesting perspective. I would love to have the panelists turn their cameras back on. We're running a little bit late in our time, but I would just love to throw one quick question out, and then we'll see if we've got time to take a couple questions from the audience. Just as a quick aside, if you submitted a question to us and we are not able to get to us during today's conversation, we will follow up with you directly. So let's go ahead and quickly ask a question of the panel. And I actually want to delve into something, Pam, that I think you touched on, this concept of employers pursuing disease management specific approaches versus a more population-based approach. In other words, I think the question I would ask for the panel, how does improving health literacy overcome the tendency for employers to want to focus on the 20% that generate 80% of the costs? Pam, I see you nodding, so I'm actually going to come to you last, if I may. And Jeff, let me begin with you. I'm sure you get this question all the time, and I'd just love to hear your quick response on that. What makes the population-based approach of med incentive so much more impactful?
Well, if you're focused on the chronics, and Al Lewis can talk about this because he's the father of disease management. And I think that experiment to date has taught us that if you're only focused on the chronics that are catastrophic today, in effect, you're chasing the horse that's already out of the barn in the pasture, and that by that time it's too late because there's somebody else in the barn, another horse, that's developing the chronic condition that will raise its head in years to come. And so this misthinking, this fallacy that we focus on the 20% and somehow magically will produce a long-term positive outcome is just, again, wrong thinking. It's a fallacy. And you really need to look at the entire population. You need to consider it the normal distribution, healthy, sick, man, woman, and child, everyone should have an ability to access health literacy and experience the process of understanding how to self-manage their health.
Al, let me turn it to you. The same question, if I could, please.
Yes, I mean, what Jeff said is, it's bad form to quote your own book. So I promise I'll only do it once. But in Why Nobody Believes the Numbers, there's a reference to Jeff, what he's saying about the 80-20 rule. And it says that everything in life has an 80-20 rule. The 80-20 rule in healthcare is that 80% of the time, there is no 80-20 rule. Okay, so you need to do the whole population. And when I find a vendor that says, well, we took the 20% that were generating 8% of the cost and they fell by, 30%. Yeah, but how about, and I just showed this on one of my slides, how about also counting the people who were not in that top 20% last year, but are this year?
I also think
when Jeff gets his validation, it includes the up to down as well as the down to up, because you never know where the health literacy is going to have the impact.
Well, and also I think back to a data point that we shared earlier. Jolie, I believe you shared this as well, that about 85% of what a patient is told during a visit is literally forgot the second they walk out the door. And that doesn't matter if you have an existing disease, if you are new to the patient office, it's a stressful environment. And so I think a population-based approach to health literacy is absolutely the right way to go, simply because the dynamics of the visit are so intense that it's easy for some of that information to be lost. And when I think about MedIncentive, one of the ways I think about the solution, it extends the value of the physician visit after the visit. And we're able to really capture the patient's attention and encourage them to learn more about their condition. Jolie, do you have thoughts on this population versus disease management approach? And have you thought about that in your research as well?
Actually, it's the inspiration for my entire body of research in this area, because what we know is that you cannot predict health literacy level by any given factor, such as like SES or education level. And so what we also know is that somebody who may demonstrate health literacy in one situation may not in another, which I think is what they're all alluding to in their comments today. So that is why I developed and validated the 4-item screening tool, is because we needed to be able to quickly assess patients in the clinical environment to understand what was happening in that given moment. And we need to continue to clinically assess them. So it's not a one-time measure. It's something that can change over time. It could be situational. So I definitely agree. And this is something that was kind of the whole justification for my body of work, which is we need to be able to assess individuals' health literacy in any given situation, because it can change and it is a fluid phenomena that needs to be addressed proactively in the clinical environment.
Yep, makes total sense. Pam, I think we have a sense of where your answer might head, but I would love to hear you build a little bit on your experience with that diabetes program versus MedIncentive, and just what were some of the key insights that you took away, just building upon anything you may have shared earlier.
Well, and I have to back up to pre-MedIncentive, actually. My father was diagnosed pre-diabetic. He was not on the list of disease states. He was not chronically ill, and he was told that he needed to change his diet. So I would check in with him every week and I would ask, Dad, so how are you doing? He said, oh, I'm doing great. I just got rid of those frosted cornflakes that I was eating for breakfast. And he had done that for years. What did you replace it with? How have you improved? He said, oh, I got the ones without the frosting. So he didn't know what he didn't know. He did not know those were turning to sugar in his bloodstream. So you have to get to the people before they get to that disease state.
Excellent. Okay. In the interest of time, I'm going to just go ahead and turn to a couple of questions that have come in from the audience that I think are quite relevant. The first is targeted to Jeff. How long does it take to see a return on an investment to improve health literacy? And specifically here, how long for the Med Incentive Program to begin to demonstrate measurable impacts in the areas that the solution affects? Jeff, thoughts on that?
Sure. As soon as a patient ingests knowledge, you have a positive outcome. And that happens the moment the program is implemented. And in terms of our experience, it is common that the outcomes that I shared with you earlier in the most recent study occurred in the first year. So it is expeditious, fast acting, and it's sustainable. It's not like a one trick pony. We see the results that deteriorate over time because you've got new people, new diseases, chronic conditions that need to be managed over time. So again, as I've mentioned before, it is fast acting, expeditious, and it is sustainable and it's scalable. I mean, it's really easy to implement.
Excellent. Great. Jeff, another question for you. It's a product related question. Is the program accessible in multiple languages?
Today, out of the box, it comes in English and Spanish. We recommend Google in facilities for other languages, unless someone comes to us and asks us. I might add that our content is supplied by two sources. One is HealthWise, which is the preeminent content supplier, fifth grade level, plain language, which is always important to those of us who are interested in health literacy, and Quizify. So those are the two content, but we're non-denominational. If someone comes along with better content, we'll adapt the incentive program around it. We're going to see more and more audio visual. I think that answers that question.
Thank you, Jeff. So in other words, enhancements coming down the line and some excellent baseline coverage for an out-of-the-box application. Pam, I'd like to actually end with a question that's coming to you. And let me paraphrase what the question is. So, obviously employers are struggling to recruit employees. I think the last number I heard is something like 9 million openings across the country. So it's a staggering whole. Could this program serve as a differentiator for employers that are looking to enhance their benefits offering to attract and retain employees? What's your thinking on that?
I really believe the answer is yes. And I've experienced it through my client. I would participate in meetings, several meetings with the client on other topics other than health literacy, other than even employee benefits. It might be turnover or whatever the issue. Every single meeting I went into, the employees would say, oh, you're the person that helped us put in Med Incentive. We love that program. It's sticky. It's sticky. It is engaging. And that is one of the biggest problems with well-being programs. If they're not engaging, if they aren't consistent, if they aren't scalable, the engagement factor goes way down. And that is something I believe Med Incentive has really, because of the provider factor, that mutual accountability keeps you engaged.
Yeah, excellent. Okay. I want to thank all of our panelists for their contribution today. This has been a fascinating hour. And to wrap us out, I would like to turn it back to Sean Edwards, and he will go ahead and close us out for the day. Sean, I'm going to turn it over to you.
Thanks, Jonathan. Thanks again to our panelists. Thanks to Med Incentive for making our session possible. Just a reminder, folks, the webinar has been recorded. You'll receive an email with a link so that you can view it again. And to get access on additional information on how your organization can speak or sponsor, please visit wcwebed.com. Thanks again for joining us, everyone. Have a great day. And this now concludes today's discussion.
Thanks, guys. Have a good one.
Have a great day.